There is a population of children that we're all working with that have kind of been marginalized over the last few years. And those are infants whose mothers use illicit drugs during pregnancy. So our webinar series this year is going to focus on that population of children. Today we're going to talk about the medical and neurobehavioral effects of prenatal exposure to illicit drugs. Now, in order to do this, we have to be able to, first of all, understand how the body responds to drugs in general. And to do this, we're going to talk first about the nervous system and the way the nervous system works. For example, if you want to wiggle your fingers, you send an electrical message from your brain to your fingers to wiggle. Now, there's not one long nerve that goes from your brain to your fingers, but it's a series of nerves. And the way that you communicate the message is the electrical stimulus travels down the nerve pathway until it reaches the end of the first or proximal nerve. At that point, that electrical impulse is picked up by substances that are known as neurotransmitters. Neurotransmit. Those neurotransmitters are also known as catecholamines. Now, there are a variety of catecholamines in your body. The one that most people are most aware of is dopamine. So we're going to be focusing on dopamine today. So what happens is the electrical stimulus travels down the nerve pathway, gets to the end of the proximal nerve, and the dopamine picks up the electrical message, carries it across the nerve gap to the next nerve ending, where the message is released and moves on, and the dopamine circulates back and is taken back up into the proximal nerve ending. That's why you never run out of dopamine, essentially, because the dopamine recycles. Now, this process is known actually as dopamine reuptake. And dopamine is known as the regulatory center of the brain. So when you want your fingers to stop wiggling, for example, the dopamine recycles back to the proximal nerve ending and stops transmitting the signal. And so it's a very sophisticated yet simple process through which we regulate our actions through this system. Now, the issue that arises is that dopamine is not only the regulatory center of the brain, it's also the pleasure center. And the reason people who use drugs is to get a dopamine stimulus. So what we see is, for example, if someone uses methamphetamine causes massive release of dopamine across the nerve ending. So instead of getting the normal amount of dopamine released, it's a massive release that the dopamine then stimulates the distal nerve ending, and that's what produces the high. Cocaine works in a different way, but the end effect is the same. A normal amount of dopamine crosses the nerve gap, but then as the dopamine circulates back, that is the reuptake process, cocaine acts at the nerve ending to block dopamine reuptake. So what you get is a flood of dopamine, excess dopamine, at the distal nerve producing a high because the dopamine can't go through this reuptake process. Now, we could talk just about any other drug you can name, including tobacco, because nicotine acts on the dopamine receptor system also. And the process is different for all the different drugs, but the effect is the same, this excess amount of dopamine at the distal nerve ending. Now, of course, the different drugs have a different level of impact. For example, just eating food will raise dopamine levels 100 to 125%. Smoking a cigarette will raise dopamine levels 200%, and using something like cocaine raises dopamine levels 300%. Using methamphetamine raises dopamine levels 1,000%. So you can see the relative difference in levels of dopamine that is available at the distal nerve ending associated with the different drugs. Now, That's how the high is produced. But unfortunately, dopamine has other effects. Mainly, dopamine acts on smooth muscle. So when an individual smokes a cigarette or uses cocaine or methamphetamine, one of the first effects is the dopamine acting on the major smooth muscle organ of the body, the heart. And so what you get is tachycardia, that is a rapid heartbeat. The other place that we all have smooth muscle is around all of our arteries. So that in cold weather, smooth muscle around the arteries contract, and it causes the arteries to contract down, obviously, also. And that preserves body heat. Now, during summertime, the smooth muscle relaxes around the arteries dilate, and we release body heat. When someone smokes cigarettes or uses cocaine or methamphetamine, the smooth muscle around the arteries constricts down. So then you have a heart that's beating hard and fast against arteries that are shut down. And of course, the immediate effect is an acute rise in blood pressure, which is why when you read in the popular press about people dying of drug overdoses, most of those deaths are related to heart attacks and strokes, the cardiovascular effects of dopamine on smooth muscle in the body. Now, the other major organ in half the population of the world that consists of smooth muscle is the uterus. And when a woman who is pregnant uses tobacco, or to much greater extent cocaine or methamphetamine, you get uterine contractions. And which we know from all the research, one of the effects of using drugs during pregnancy is preterm labor. So that use of these drugs can cause the uterus to start contracting, and the woman can go into premature labor. In addition, you get intrauterine growth retardation. Now, some of this, of course, is especially among women who are using drugs during pregnancy. Some of it is related to nutritional issues. But a good aspect of the intrauterine growth retardation, that is the failure of the fetus to grow appropriately, one of the major issues is that the dopamine that is at high levels, remember, because the woman has used a drug, the dopamine acts on the smooth muscle surrounding the umbilical arteries. So that studies have shown that when in animal studies, they give cocaine to, for example, to a pregnant sheep, and they can use real-time ultrasound and have shown how the umbilical arteries constrict down. Now, when the umbilical arteries constrict down, blood flow from mother to fetus can't occur. And so what they show in the fetus is that the fetus becomes hypoxic, so is lacking oxygen. And of course, intermittent periods like this of blood flow being interrupted through pregnancy, which means that you're interrupting flow of oxygen and nutrition across to the fetus, that is a major reason that these babies can be born growth retarded. And finally, there's abruptio placentae. This refers to when the placenta separates from the wall of the uterus before the baby is born. Now, through a normal labor and delivery process, a woman goes into labor, the uterus contracts, the fetus is delivered, and then the placenta will separate from the wall of the uterus, and that's the afterbirth. However, due to the significant vascular damage done to the placenta from use of things like cocaine, methamphetamine, you get a placenta that is weakened in its attachment. And so as the woman goes into labor, the placenta can separate from the wall of the uterus before the baby is born. And of course, you get significant hypoxia, you can get brain damage to the fetus, and this is extremely dangerous for both mother and baby. Now, animal studies have shown much of the same things that we have found in human research. Now, these are two baby rat pups. They're both 10 days old. The one on your right was born to a mother who said no. The one on your left is born to a mother who was given cocaine during the pregnancy. Now, these studies were done by Dr. Wayne Church in Detroit. And what they show is that the baby whose mother was given cocaine during the pregnancy is significantly smaller at birth. And so the issue of intrauterine growth retardation has clearly been demonstrated in animal studies also. Now, of course, in humans, we can't do these kinds of studies. We can't line up pregnant women and randomize them so that, okay, you take cocaine, you don't. You take methamphetamine, you don't. Even you smoke cigarettes and you don't. You can't do those studies. And so in working with pregnant women, what we're able to do is collect data and analyze it through different statistical approaches to ask questions such as, in a woman who is using drugs during pregnancy, when you take all the factors into consideration, what, for example, is the most dangerous drug to be taking in relation to low birth weight? And when you analyze the data, what we find is the single drug that is most directly related to producing low birth weight is not cocaine or methamphetamine, it's actually tobacco. And statistically in our studies, tobacco has a 3 times greater impact than cocaine on predicting low birth weight in infants. So I think this information reminds us that tobacco is a drug of abuse. Now, we've been talking about the complications of pregnancy, and these translate into direct complications for the newborn. The first is prematurity. Of course, if there's a high rate of preterm labor, there's going to be a high rate of prematurity. That is a baby born prior to 37 weeks. In addition, there are high rates of low birth weight due to the intrauterine growth retardation. And let me just mention here, low birth weight is defined as a baby weighing less than 2,500 grams at birth. That is about 5 pounds, 8 ounces. We also see an increased rate of failure to thrive in these infants. And this is related to the irritability and the feeding difficulties they may demonstrate early on. Exposure to cocaine, methamphetamine, even tobacco can cause irritability in the infant, a problem coordinating suck and swallow, and especially if the mother has used opiates, the baby may go through an abstinence syndrome due to the mother's opiate use. And in that case, the baby is irritable, has trouble sucking and swallowing, is having difficulty with sweating, tremors, and so those babies also have feeding problems. The 2 groups of infants that we see with the highest rates of failure to thrive are babies born to mothers who have used opiates during pregnancy and mothers who have used methamphetamine. Now, the methamphetamine-exposed infants are kind of interesting because although we tend to think of drug-exposed infants as being irritable, hard to console, thrashing around, that's what we have in our mind, actually a great many of the methamphetamine-exposed infants basically are so overloaded, are so irritable that the only way they can protect themselves is by shutting down. So that those babies have very poor feeding, have a very poor suck and swallow. You have difficulty arousing them, and so they skip feedings and they sleep through their feedings. And especially if you have a family in which drug abuse is occurring and nobody is paying a whole lot of attention to the infant, if the infant is sleeping all the time and not crying, he's not going to get fed. And we've seen many instances of this with infants exposed prenatally to methamphetamine. The other issue that comes up is sudden infant death syndrome. Now, there are no really good data that tell us how much more common SIDS is within this population of infants, but it certainly does occur at an elevated rate. But when you look at all the data and match all the drugs to rates of SIDS, and I should mention that SIDS is crib death, what we find is the one drug that produces the highest risk for dying of SIDS is in fact tobacco. Babies who even are born to mothers who did not smoke tobacco, who did not use any drugs during pregnancy, but then, for instance, are adopted into a home where someone is smoking cigarettes, those infants also are at increased risk for SIDS. So secondhand smoke can produce increased risk for the infant. Again, this reminds us tobacco is a drug of abuse. The next is dysmorphology. Now, what do we mean by dysmorphology? Dysmorphology is different from a malformation. When you say malformation, it implies that the baby was formed abnormally, such as a baby being born with problems with the heart malformations. What we're talking about here is not an increased rate of malformations with newborns whose mothers use illicit drugs, but we do see a higher rate of dysmorphology, which means the baby was formed normally, but then something happened during the pregnancy that caused that normal formation to be affected. An example of this is this baby. Now, this is a newborn infant whose mother used cocaine during the pregnancy. She was a heavy user, and she was in one of our treatment programs, but continued to use through the pregnancy. The baby was born missing the two middle fingers of her right hand. How did that happen? The baby was formed normally, so this is not a malformation. The baby was formed normally, but the mother used cocaine. The cocaine does cross over the placenta to the fetus and causes release of excess dopamine. The dopamine acts on smooth muscle, in this case, smooth muscle around these two middle fingers. The middle fingers contracted down, the oxygen, the blood supply was cut off, and these two fingers infarcted, they died. So when the baby is born, she's missing these two middle fingers. In addition, this little girl was born with no uterus, no left kidney, and no colon. And so she had to have a colostomy done. So it's all based on the same effect, which is dopamine, because the cocaine crossed over into the fetal side. The cocaine then caused vascular contraction, cutting off blood supply, and you get a limb reduction deformity. Now, this same thing has been shown in babies whose mothers use methamphetamine. Now, this is an animal study out of Australia, and what we're looking at here is a fetus whose mother was given cocaine, and 24 hours later, the fetal rat was delivered by C-section. And what you can see is this vascular damage in the extremities of the fetal rat. So it's the same thing being shown in animal studies as I just showed you in the little girl. This baby is one of the first babies in the mainland U.S. Who was prenatally exposed to methamphetamine. And what you see here sticking out of the back is called a myelomeningocele. And that's when a baby is born with his spinal cord sticking out of his back. And it's due to a vascular disruption. That is, as the spinal cord and the vertebral bodies were forming, the mother had used methamphetamine. It caused a vasoconstriction in this area, and the baby was born with the myelomeningocele. This is the same infant from a frontal view, and what we see here is the limb reduction deformities, the same kind of dysmorphology I showed you in the little girl previously, has occurred in this baby's extremities also. And then you also can get direct central nervous system or brain damage from prenatal exposures. And this story is a case study that we published many years ago. We had a mother from the North Shore of Chicago who her husband had given her as an anniversary gift 5 grams of cocaine. Over a period of 3 days, she used, and she was at term in her pregnancy. Over the last 3 days, over a 3-day period, she used the 5 grams of cocaine, noticing some increased fetal activity, but not paying that much attention to it. On the 3rd day, she called her husband, who was at work, and said, "Come home, I'm having our baby, I'm in labor." He rushed home. They made it into the hospital, and it was noted in the nursing chart that the mother seemed drunk. So they did a blood alcohol level, and it, of course, was 0. Another nurse wrote in the chart that the fetal heart rate was about 200 beats per minute, which is an extremely high fetal heart rate. So they thought something was wrong with the fetal monitor. So they went to get another monitor. In the meantime, she was ready to deliver. She delivered a term infant. The APGAR scores were 1 and 6. A pediatric resident rushed down to the delivery room to resuscitate the infant, and then went to talk with the parents and said, "Congratulations, your baby is looking great now. He had a little trouble in the beginning, but we've got him going, and everything really looks fine. The only thing I'm concerned about is he doesn't seem to be moving his right arm. And I'm concerned that he may in fact have a fractured clavicle. That is a fracture of the right collarbone, which is why he's not moving his right arm. And so we need to do an X-ray of the clavicle." Well, the mother looked at the pediatric resident and said, "What, expose my baby to X-rays? No." So she refused the X-ray. They called the private pediatrician, who said, "Well, we don't treat broken clavicles anyway, that's fine." So they sent the baby on up to the normal newborn floor with his mother, where the baby was taking bottle feedings fairly well. The nursing notes did not indicate any particular problem. And then at about 12 hours of age, the baby suddenly began having seizures all along the right side of his body. He arrested. The baby was rushed to the neonatal intensive care unit where he was resuscitated. And just as routine practice, when babies have seizures, newborn seizures, one of the things we do is a urine toxicology. And it came back with high levels of cocaine in the baby's urine. In addition, we did a CT scan of the baby's brain. Now, this is a CT scan looking from above, and all this white matter out here, what looks like speckled white matter, that's all fairly normal brain tissue. But if you look in this area up here at the upper left, that is an infarction in the distribution of the left middle cerebral artery. So this baby basically had an intrauterine stroke from his mother's cocaine use. Now, I mentioned earlier that young adults who die of drug overdoses, often it's from strokes and heart attacks. This was the first published case of a baby having had an intrauterine stroke. But since that time, there have been studies in NICUs across the country, and there have been other published articles about infants whose mothers have used especially cocaine or methamphetamine during pregnancy, those babies having intrauterine strokes and heart attacks. Now, that's the bad news, and everything I've shown you at this point is bad news. But there's some good news here. Most of what I've been able to show you so far is all the result of dopamine acting on the fetal vasculature to produce the stroke, to produce the limb reduction deformities, the dysmorphology. The good news is that smooth muscle in the fetus doesn't develop until the 3rd trimester of pregnancy, which means if you identify the pregnant woman who's using cocaine, methamphetamine, these other drugs, and get her into treatment, and she stops using by 3rd trimester, you prevent almost all the complications I've told you about. Now, we published that article in 1992, so this is not new information. But in 1992, we published a study in the Journal of the American Medical Association that shows if you identify, in that case it was cocaine-using women, and get them off cocaine by 3rd trimester, you significantly reduce the rate of prematurity, low birth weight, newborn seizures, dysmorphology, intrauterine strokes and heart attacks, all the kinds of things we've been talking about. Unfortunately, not too many people pay attention to prevention studies. And so we still find ourselves many times laboring to take care of infants who were prenatally exposed and have just horrendous outcomes, when if we had identified the woman in first trimester and gotten her into treatment, we could have prevented a lot of this. And so one of the directions that we have to take has to be driven by our question, what can we do to prevent these complications? Now, the reality is that I have shown you the medical complications, but they only occur in about 25% of the babies at most, which means that 75% of infants born to mothers who use cocaine, methamphetamine, opiates, even tobacco, but 75% of those babies look perfectly normal. They have normal birth weights, they don't have any medical complications, and they're in our newborn nurseries looking perfectly fine, and unfortunately get sent home early. Where the problems really lie are in the neurobehavioral aspects. And so we've talked about the medical complications. Now we're going to turn our attention to neurobehavior. So let's talk about newborn neurobehavior, and the first thing we have to do is define what we mean by neurobehavior. Neurobehavior is the way an individual, no matter what age, the way an individual reacts to and responds to the environment, the world around him or her. So in a newborn, what we want to do is assess how the newborn responds to different stimuli that we give him. And in order to do this, we use the Brazelton Neonatal Behavioral Assessment Scale to assess the infant's neurobehavior. Now, there are multiple steps and multiple domains, and actually there are 7 domains or areas that you look at on the Brazelton. But I'm going to focus down on 3 of those areas because these are the 3 areas that we find that the infants are most vulnerable, have the most problems. The first is the motor skills. Now, when we look at motor skills, well, first of all, when you do the Brazelton, you take the baby into a quiet room and undress him except for his diaper, and then try to wait until he's quiet and calm and appears to at least be awake. You then can test motor skills. And what we look at are reflexes, equal movement of the baby's arms and legs on each side, the regularity of the movement, the smoothness of the movement, and look for things like tremors and hyperreflexia. Now, what we see in a number of infants who have been exposed, especially to cocaine, methamphetamine, opiates, PCP, those drugs often will cause hypertonicity, that is, increased muscle tone in the trunk and in all the extremities. And you'll see tremors. And this is kind of the picture that most people get in their minds when they think about babies who've been exposed to illicit drugs. So that kind of classic picture where the baby is really irritable and tremulous, may have a high-pitched cry, and that's often the picture people think of. But a good number of infants can be the very opposite. And especially babies born to alcohol, for example, often will be hypotonic. That is, they'll be very flaccid. And when you try to pick them up, they almost feel like they're going to just slide right through your hands, like you're picking up a 5-pound bag of flour, and that bag is not giving you any help picking it up. Alcohol-exposed infants can look like that, and a good number of cocaine and methamphetamine-exposed infants will be hypotonic rather than the hypertonicity I described earlier. And that's kind of surprising to a lot of people. But I think the reason we see that, as I mentioned with the methamphetamine-exposed infants, I think they're so irritable and they're so overloaded by the world around them that the only way they can protect themselves is by shutting down and being very flaccid and non-responsive. So from a motor perspective, you can see babies across an entire spectrum. Where you can really hone in, though, is next looking at orientation. And in order to pick up, let me just say, in order to pick up on a lot of these things, you don't have to do or to be trained in doing a Brazelton. A good clinician can make some of these observations very informally. With orientation, for example, take a bell or a rattle and ring it to one side. And you can do this as early as 24 hours of age, all the way through 28 days. So ring the bell or rattle, and what a normal newborn should do by 24 hours of age is show some alerting response, and then may turn his head toward the sound, or at least move his eyes toward the sound. And then you ring the bell or rattle on the other side, and the baby will turn her head toward the other side, or at least move her eyes. So what she's doing is orienting toward that auditory stimulus. And this is called inanimate auditory orientation. So the next step now is just giving the baby your voice and speaking to the infant very softly and seeing if the baby shows that same orienting response to your voice to one side and then to the other. And that's what normal newborns should do when they orient to sound. The next step is visual orientation. So what you're going to do is take a bright object, I often use just a red or a yellow ball, and hold it about 18 inches from the baby's face. And what a normal newborn, as early as 24 hours of age, should do is orient, or at least look at, that object you're holding about 18 inches away from his face. And if you move it a little bit, what you'll see is babies that age might even track a bit and watch the object. Now, they can't cross the midline and they can't track very far, but you'll see that the baby is orienting toward that object, that inanimate object. The next step then is to give the baby your face and try to catch his eye. And you know, you've worked with newborns, and so you know that you can position yourself, and even a brand new newborn infant will gaze at your face, at least for a short period. And if you move a bit, the baby may even track you. Now that's normal, animate and inanimate visual orientation. Babies who have been exposed to many of these drugs we're talking about don't respond that way. Often what you'll see instead is when you ring the bell or rattle, or when you give the baby your voice and speak to the infant will show alerting responses. So you know he hears you, but then he starts getting frustrated because he can't figure out where the sound is coming from. So he's not able to orient toward the auditory stimulus. The next step is when you give the baby that visual stimulation, such as that red ball, the baby may glance at it, but then will move away immediately. Or especially when you try to give the baby your face and make eye contact, the baby really starts getting overloaded. It's just too much stimulation. And so what you'll see is the baby may glance at your face and move away immediately. And then if you work hard and try to get the baby to look again, he will move his eyes away immediately. This is called gaze aversion. The baby is averting his gaze from this stimulus because it's just too overloading. Now, if you persist in this and keep trying to get the baby to orient toward you, especially your voice and your face, the baby will start getting overloaded and stressed. Now, this is an important point here because many of our mothers and fathers who are working with babies exposed to drugs and alcohol will try at this point to keep working harder to get the baby to respond to them. And so you see an escalation of behaviors both from the mother and the baby. And so what we have to teach our families is that you have to look for newborn stress. And what's the first sign of newborn stress? It's not crying. It's yawning, sneezing, and hiccuping. That's how a newborn infant first shows he's getting stressed, by yawning, sneezing, and hiccuping. And I have lots of families, both biologic, foster, and adoptive, who come in and say, our baby has allergies because he's sneezing all the time. And it's not allergies, it's the fact that the baby is getting so easily overloaded. Now, if you keep trying to stimulate the baby and that overload continues, he gets more stressed, After the sneezing, yawning, and hiccuping, the next step is you'll see the baby start turning pale around the mouth. It's called circumoral pallor. So he gets pale around the mouth, and then you'll see him start flushing, and then he'll escalate very rapidly to crying and irritability. And what we want to teach our parents is that when they start seeing those early signs of stress, you step back and you let the baby try to gather himself into a more calm state. Because babies exposed to drugs prenatally have difficulties with state regulation. That is, the ability to regulate states of arousal. Think of a normal newborn infant sleeping in his crib. He'll begin to awaken, will become alert, more alert, and might even reach that nice alert responsive state where he's looking around, and then may start to escalate, start getting more irritable, and then reach a peak of crying and irritability. So that smooth transition up to a crying state. Now, if you don't go into him right away, or just observe him, what he'll see is the baby will self-soothe. Most newborns have the ability, they'll begin to rock their head, they'll bring their hands to the midline, and they'll maybe even suck on their hand or thumb, but you'll see a smooth, self-soothing transition back to a quiet state. So newborn infants will make smooth transitions between the various states of arousal. In a newborn who's been exposed to any of these drugs we've been talking about, you don't see these smooth transitions. Rather, what you see are very abrupt transitions. I call it yo-yo behavior, because the baby will be quiet and sleeping, and just as suddenly be very irritable and crying, and then suddenly drop back down to a deep sleep again. So it's kind of yo-yoing back and forth. And the difficulty is for parents is they never quite know what the trigger is. They never quite know what's going to happen next with that baby. And that's why so many parents, whether they're biologic, foster, or adoptive, need support in those early, especially in that first month, when caring for an infant exposed to drugs and alcohol. So these are the key issues that we have when we talk about newborn neurobehavior. And today we're only going as far as the first month of life. Now, future webinars, we are going to talk about the children as they get older. But the question right now arises, why do these neurobehavioral difficulties happen? And there's something I didn't tell you about early on in this webinar. There's a step I left out. So let's go back to that very first slide I showed you when we started out. And what you see here is, remember, the dopamine picks up the electrical message, travels across, releases it, and then there's the dopamine reuptake. The part I didn't tell you about is that when you use methamphetamine, for example, with that rush of dopamine across the nerve ending, what happens is you begin to deplete your dopamine receptors. And when you deplete your dopamine receptors, how do you feel? You feel irritable, off task, and the only thing you can do to make yourself feel better is to use more methamphetamine. Same thing with cocaine. Cocaine blocks dopamine reuptake. So what you get is depletion of the dopamine receptors in the proximal nerve ending. And the only way to feel better is to use more cocaine to stimulate whatever dopamine is there. So this is the process of addiction. And many of the drug and alcohol using men and women that I've worked with have told me they start using drugs to feel good, to get that high, but they keep using drugs so they don't feel bad. And this has been shown in a variety of studies. Now, this is a PET scan, and we're looking from above here at a young man. On the left is a normal PET scan, and we're looking from the top down of the brain. And in PET scans, dopamine shows up in the brain as the yellow and red that you see highlighted here. And the yellow and red are in the prefrontal cortex where dopamine resides, And those are normal, that's a normal PET scan. Now this young man happened to start using cocaine and had another PET scan a year later. And when you look at the PET scan on the right, what you can see is the yellow and red are missing. And so what's been shown in human studies with adults is that with ongoing cocaine, methamphetamine, even tobacco use, what you get is depletion of the dopamine receptors. Now, this has not been shown in human infants or children. So, but in animal studies, pregnant rats given cocaine when their babies are born, those babies on PET scan do have depletion of dopamine receptors in the prefrontal cortex. So again, be careful. These studies have not been done in human children, but the kinds of behaviors that we see, this lack of regulation, such as demonstrated with the babies I told you about, with poor state regulation, is consistent. That behavior is consistent with depletion of dopamine receptors. Now, to help illustrate this a little further, I want to show you a video of a baby with neurobehavioral difficulties. Now, this is a newborn infant whose mother was 18 years old and used PCP, cocaine, and alcohol during the pregnancy. This is at 12 hours of age, and what you can see here is the tremors, but more importantly, look at the state regulation. See how the baby reaches a peak of irritability? Now watch him, he's just going to go, here's that yo-yo behavior, straight down into a deep sleep. Look at the irritability, but look more importantly at how he moves from one state of arousal to the next. And you can see the tremors here. Now, as I'm diapering him, watch this peak. Again, he's going to reach a peak of tremors, irritability, and now he's trying to self-soothe by taking himself down into a deep sleep. Here's some motor behavior. You see I'm pulling him up, and you can see how stiff he is. Babies at 12 hours, of course, his head should be showing significant head lag. But what we're seeing is that his head is coming right up with his body. Now, he's getting a little tired here. And you can see how stiff his arms were. So there's some of the motor behavior I was talking about. Hypertonicity, tremors, and these real, movement very rapidly between states of arousal.